On a snowy day, snowy several days, I guess. I'm going to call this meeting of the Seneca Healthcare District Board to order at, what do I have, 3:01. Start by taking roll. Attendance, Dr. Walls,
Here.
Kristen Montgomery,
Here.
Rich Rydell,
Here.
Jerry Nielsen,
Here.
and I am here as well. That takes us to item number 3 on our agenda, which is our public comment period. It's an opportunity for members of the public to address the board. I should note that comments are limited to 3 minutes. I'd also ask TK or any Renee or somebody if there had been any written comments submitted.
Do we do the pledge after that or before?
No, I'm sorry, I skipped right over it. Yeah, I'm sorry. Let me hold off on public comments. So we will do the Pledge of Allegiance. Please join me. I pledge allegiance to the flag of the United States of America and to the republic which it stands, one nation, under God, indivisible, liberty and
justice for all.
Thank you very much. I apologize for skipping over that. So public comment. Any members of the public on the call, on the Zoom line, would like to address the board? Now's the time to do that. I believe you have to raise your hand in the Zoom meeting, and TK can identify you if you're raising your hand.
Jen, at this point, I don't have any hands raised. I'm not aware of any submissions. Those that are joining us by phone that do not have a computer, you can use *6 to unmute your line and address the board.
I'll give it just a minute and then I'll move forward. Anyone wanting to address the board? Okay, that moves us away from the public comment period. Item number 5 on the agenda, which is the approval of the board minutes from our December 31st meeting. Board members, if you had a chance to review that and noticed any modifications or corrections needed, please indicate so now.
And this is Jerry. I just had a minor one where the board rescinded policies. I think it needs to say, instead of move to approve the, move to approve the rescinded policies, it should say move to rescind the following policies. That's at the bottom of number 9, item 9, under policies and procedures.
Okay, so can we have that adjustment made? And with that adjustment made, if there's nothing else, I'd look for a motion to approve the minutes with that modification to rescind as opposed to approve.
I'll make the motion.
Okay.
I'll second. It's Dr. Walls.
Jerry Nielsen makes a motion to approve the minutes. Dr. Walls seconds. Kristen, how do you vote?
Aye.
Rich?
Aye.
And Dr. Walls?
Aye.
And I'll vote aye as well. So the minutes are approved from the December 31st meeting.
And Ken, this is Jerry. I also vote aye.
I'm sorry, thought I said that. Okay. Ed staff report. We have some initial appointments to approve here and reappointments of staff. Dr. Cooper, is there anything you'd like to say about this, or are there any questions from board members related to these appointments? Hearing none, I'd look for a motion to approve the initial appointments of these 3 individuals: William Lusinger, Darcy Tranquil, and Michael Zoglio as initial appointments. Can I have a motion for that, please?
And I'll certainly make the motion to approve them. Just so everyone knows, those are on the telemedicine physicians.
Telemedicine physicians, thank you. Dr. Walls makes the motion. And second,
I'll second. This is Kristen.
Kristen. Okay, Jerry, how do you vote?
Aye.
Rich?
Aye.
Okay. Kristen
Aye.
and Dr. Walls?
Aye.
And I'll vote aye as well. Second item on here is the reappointments. Dr. Eric Goldberg, Leon Jackson, and David Dempsey. Can we have a motion to approve those?
I'll make the motion to approve them.
Okay.
And Dr. Wells, are A and B, are those both also telemedicine?
No, the radiologists they read the films. I think they come up to Banner Lassen from Reno.
Okay, thank
And
you.
Dr. Dempsey lives out of the area, but he's an ER physician.
Okay, I'm sorry, Dr. Walls, did you make that motion?
Yes.
Okay,
I'll second, Jerry.
Jerry has a second. Okay, Kristen, how do you vote?
Aye.
Aye. And Rich?
Aye.
Okay, Dr. Walls?
Aye.
Kirsten, did you vote? Kristen?
Yes, I already did.
Okay.
I voted
And
aye.
who did I miss here? Myself, and I'll vote aye. Okay, so we're done with item number 6, the med staff report. Dr. Cooper, anything else from the med staff? Hearing nothing, I'll move on. Moving to policies and procedures. We have 2 policies and policies. One is abbreviations, and the other one is quality assurance and peer review. Any commentary from the board?
I had a couple of questions on this one, Ken. And the first question that I had was the reason for this particular policy.
Which
is
one are you referring to, Jerry?
I'm sorry, the abbreviations.
Yes.
Because I'm looking at the attachment B, page 14, where it talks about the do not use abbreviations. And it talks about writing items. And my understanding was that all of our orders should be going in through our EHR. So I'm questioning why we're talking about writing any of these things.
Well, occasionally, we have problems with the equipment, and then we have to write orders.
Okay, so are we also going to be, or are these already default items in our EHR such that the do not use abbreviation piece is not an issue in the EHR, or should we be noting that these will also be enforced in the EHR? Because I didn't see anything in here related to that at all.
Yeah, and I can't answer that. I think TK would have to address that. Personally, I will tell you, this policy is more of a recommendation. I don't know of anybody that strongly enforces this. You know, nobody goes around and slaps fingers or anything like that. And a lot of these, like MS, morphine or multiple sclerosis, we're just trying to get people to clarify the orders so there aren't mistakes.
Yeah, and I can appreciate that, Dr. Wells, but then I also wonder when we are audited, and this could potentially open us up for a whole slew of audit findings, right? Especially if it's not being enforced in the EHR.
Yeah, I just can't address that. Like I said, I think you would have to ask TK.
Is she still on?
TK,
Yes, here. Can you
Did
hear
you-
me okay?
Did you hear the conversation, TK?
Addressing abbreviations in the EHR.
Yes.
I have not read the med staff document. I can certainly review it. In regards to the morphine, I did catch that. That is absolutely spelled out. As far as the diagnosis for multiple sclerosis, that information is loaded from Evident into the problem list area, in which it is absolutely spelled out. So I can go ahead and take a look at that abbreviations list and see in any other parts of the program where it might appear, to ensure that we are compliant as far as either spelling it out or adding description to ensure that there's no misunderstanding. There are some shortcomings with evident in that there are certain fields that are held to a character limit. But I would have to go through and review that before I can give you an absolute confirmation that that has been reviewed entirely.
Yeah, I think that might be necessary, TK, because there's a whole slew, there's like pages of approved abbreviations, and I would hate for that to conflict with what we have in our EHR, and then for that to come up
Sure.
in an audit.
Yeah, I can do a review and comparison.
The
I mean, would-
additional piece related to that, if I can jump in here, is on the abbreviation list. It's quite long. And if I recall correctly, there is some language in there about disciplinary action for not adhering to those abbreviations. So I don't know if that language is overstated or understated, but that language does exist in there. And if we have that language, I might agree with Jerry that an auditor might take some exception with that.
Sure, I can go ahead and do that review and then present my findings if there's an area that I feel that we have any shortcomings.
Now,
Yeah.
I mean, is there any of the med staff that disagree with what we're talking about right now?
I don't, and I don't know how many other members of the medical staff are here.
The other question, Dr. Walls, and TK, I don't know, maybe you can speak to this. What is the urgency on this? Is there a time frame, or is there some urgency to getting this approved?
Once a year, we do this. Once a year, the abbreviation list is revised. And I think there are some recommended standards for abbreviations that are incorporated into this. I don't understand the whole process myself. I can just say that the problem with abbreviations is becoming less and less significant as we use an electronic health record,
Right,
because everything's already programmed in there.
Right.
When we used to handwrite notes and handwrite orders, it was a big deal, but it was never as big a deal as just the penmanship itself.
But it seems to me that the review from TK would then be to make sure that in evident we have the approved abbreviations, it's updated, that we've had it patched and updated to, if we do get an audit, then it's at least up to date with acceptable abbreviation table. So that sounds to me like maybe the ask is, has evident updated this to the acceptable abbreviation tables? Is that?
Yeah, I think it needs to match. And then this document where it talks about writing, I mean, I think we need to be specific about this being limited to those orders that, are necessary to be written because of, the EHR not being
Downtime.
available or whatever. Yeah.
So, yeah, so maybe we need to bring some language into this to say that these abbreviation tables will be adopted by physicians during a downtime where automation is not available or something
Yes.
to that effect.
Yes, I would agree with that. Because I looking at this, it almost looks like we're continuing to write, written orders constantly. And I don't want, I don't want to think that's happening.
I don't want you to think that's happening either, but it does.
and I guess I would
Good point.
encourage you to look at that language related to what type of disciplinary action. There was some language in there, just make sure that's appropriate. Not objecting to it, just want to make sure that's appropriate.
I think that's consistent language that appears down at the end of pretty much all of our policies, Ken.
Yeah, probably. All right. Okay, so we will take item number 1 under policies and procedures. We'll table that until the next meeting. The next policy is quality assurance and peer review. Any discussion, comments related to that?
Frankly, I'm encouraged by this. I feel like this is looks like a really good step in the right direction for us. What I'm hoping is that we will have some in-depth training at all levels of our staff so that they understand these processes and how it impacts them individually in their own work area. I don't know, Sean, if you can speak to that, if you guys have had some conversation around that yet.
So we've been discussing, I'll just in general,
There's a reverberation there, John, on your microphone.
not mine. Somebody might just go on mute if you're not
That's
not
better.
actively speaking. Education actually has been a subject Jerry, of late, that has been on the top of everybody's mind. And some of the leadership here, we've been discussing lots of different type of education. I met with Chelsea this morning in compliance, once again, to talk about the types of things that we need to educate on. So I won't get to it. It's in my CEO report around some of the training that we've started doing or we're going to start doing, but certainly training is on the top of it, and complete exposure for all staff to understand their roles, responsibilities as it relates to QA, compliance, and things like that. So it is definitely something that's in the works.
Wonderful. I'm happy to hear that. And then my other question, sorry for monopolizing, I'll let somebody else speak in just a second. I just had another question about it. As I scrolled down to the attachment B, where it talks about the peer review indicators, let's see, page 15, I noticed there are several sections there listed as tables, but there are no indicators listed. And so I was hoping someone might speak to that because I didn't understand why those were blank.
Who's submitted this quality assurance, Karen or Dr. Cooper? Do you want to discuss this as it relates to these tables being empty? Clinical random chart pulls we're pulling random chart pulls and surgical procedures.
You guys hear me now?
Yes, there you go, Dr. Cooper.
Sorry, I've been here the whole time, but I've been having technical difficulties. I'm not for sure. I don't think I have the same packet that Mrs. Nielsen has. So I don't know why it would be left blank.
So Dr. Cooper, we're looking at what was provided to us, MedStaff 012.001 QA and peer review, if that helps.
I don't have that here. Joanne's not here right now, so she would normally have that for me. So I can't respond to that.
Jerry, this is Stacey. Are you looking at page 15?
Yes, 15.
I don't pull those ones, and I see what you're asking about, but we can definitely look into it because I'm not sure what's supposed to be in there. We only do the ones on the clinic side, but I can go find out and report it back to you for next time. It might have been like an error in the document, but I'm not sure.
So I don't know, Sean, if we should be approving this subject to a revision of these sections. I don't know how you want to approach this.
I think that we need clarity. I mean, if these are measurements that are going to be measured and then peer reviewed, we need to ensure that we have them filled out so that we understand what's being peer reviewed, how it's being peer reviewed. So this looks incomplete, especially the random chart pulls. What are the indicators we're looking for? That's my question in the policy is, as we pull the chart pull, what are we looking for? It's indecisive. Right now, it doesn't say anything. So I would recommend that we revisit this at the next board meeting where we have a complete document. We understand fully what we're chasing.
Okay, and then my last question on this is regarding compensating our staff, including our salaried staff, for participating in this process, because you know, we all know that everyone's time is valuable, but we also know that this is an extremely important process. So I'm hoping that perhaps we can put some thought into how we might ensure that people's time is properly, you know, accounted for and compensated for doing this.
Okay. Quality assurance is part of what we do. It's not something that is an addition to our tasks or anything, so we can look into that. But QA is something that as a healthcare facility is part of our job description.
No, you're right. You're right. I'm just talking about our hourly folks versus our salaried folks.
Okay. So
Yeah.
time are we spending on this versus, okay.
Right.
Dr. Cooper, can you guys hear me?
Yes.
Yeah, speak up a little.
Barely.
Okay. Usually in the medical staff bylaws, usually utilization review and things like that are actually part of your responsibility of med staff. And every hospital I've been at, it was never compensated. It was just part of your responsibility to participate.
Yeah.
So when it comes to physicians and salaried people, then that's just part of the requirements.
I think Jerry was specifically related to the data gathering, the time it takes to put this together, data gather. Obviously, it goes in front of medical staff, but this does take a lot, especially chart pools and things like that. This is a lot of data gathering that isn't necessarily electronic. So we have to pay close attention to the amount of time it's taking us to pull these and make sure that it is compensated for. So it has less to do with medical staff, Dr. Cooper, and more to do with the support staff putting together the data for us. Is that a fair statement, Jerry?
It is. Thank you, Sean.
Okay, so folks, to move this forward, this item number 7 of these 2 policies of abbreviations and quality assurance and peer review will be put over to our next meeting. I'd make one request here that when we have an item, policies and procedures here, on most of our items, we have identified who will speak to this this agenda item. So I'm wondering if in the future we can have a name attached to these things.
Yep, we'll note that for Renee. We'll note to make sure that we have a person assigned to speak to these.
Yeah, thank you. Okay, item number 8. This December financial report with Steve. So I guess you're up, Steve.
Yep. Hello.
Hello, Steve.
Can you hear me, guys?
Yes.
Okay, fantastic. All right. So as Ken said, we're looking at the month of December, and I guess I'll preface this with saying that we had our treasurers meeting last Friday and went through the information. Rich and Sean were there. Unfortunately, Ken, it was kind of short notice, so Ken could not make it. We went through the financials in great detail, and I think I'm going to try and be brief in my narrative, but allow you all to please ask any questions that have been raised from your look at the financials. But the big thing about December is that we actually had COVID present in the facility for the first time during the pandemic, and mainly had it in our nursing home. And it affected residents, it affected staff, and it had a huge impact on our revenue for the month. Our revenue for the month, gross revenue, was under budget. A little over $400,000. However, as in contrary to the past, where it was almost all outpatient, it was a combination of outpatient and inpatient revenue. The outpatient still was the significant negative variance, just under $263,000 of the 404. But the inpatient was also under 141. And one of the big pieces of this is that when we did our, the budget as it is, when we projected our numbers out, we were looking at December of 2020 as when we would start seeing a diminishment of the impact of COVID. And thus, we thought that we'd be able to start doing placements in the nursing home. And so we reflected that in the budgeted revenue for long-term care, SNF, and we were $60,000 under budget. We're also under budget for on the acute side, $58,000, and the ancillaries as well. So the good news is that whenever our revenue goes down, we have a positive change in our payer mix, and it provides for higher reimbursement, and we have higher net patient revenue. And for the month, our net patient revenue as a percent of gross was 56.6 versus 56.9. Now that sounds like it's not positive, but we also had continue to have significant adjustments related to COVID testing whether it be the surveillance of our employees or some of the mass testing we did for the public. So overall, our net patient revenue was 243,000 negative variance. The expenses mainly fell in line. The only variance was that we continue to experience the costs of COVID testing supplies, and we had a negative variance of just under 73,000. We did see if you look at the outpatient revenue in your materials, that the lab was generating more revenue, but some of that is non-billable, as I mentioned. The professional fees, medical, we have analysis of that. It's a combination of the one open office right now and that the volumes in the clinic have been down. So the RVU-based payments have been lower. The thing that made us have a positive variance to budget was we received an unbudgeted, unexpected payment through the Prime Grant Program, $483,447. So this led to having a positive variance to net income of just over $227,000. And this 483 was Jared Nielsen had brought up at last month's meeting. She quizzed me on intergovernmental transfers and didn't have a great answer. So that 483, we did the intergovernmental transfer in the month of November for $211,750 and then received the 447 in December. Now here in December, we also did an intergovernmental transfer of $292,675. And this is with the Hospital Quality Assurance Program. And we are scheduled to receive $643,891. And the best estimate right now is that will come to us in the middle of February. We should also receive our first installment on our property taxes either this week or next week, and that'll be in the range of $250,000 to $275,000. We still have the rate range, supplemental payment IGT transactions that take place where we'll have something to the tune of about $1 million, a little over $1 million IGT, and then we'll receive a little over $3 million return in a supplemental payment. We're also scheduled to receive our cost report settlement, maybe not February, very possibly March. And the as filed cost report had $1.4 million as a receivable from Medicare. As we discussed, I think that it was due to the impact on our cost reimbursement related to COVID. So we still have the stimulus funds and the PPP loan funds. So our balance sheet is very strong still. The projection we have for the remainder of the year is that we, with the supplemental payment programs and the supplemental payment programs, we'll have a positive net income for the year. So I guess it's as best as we could hope for. So are there any questions?
Questions, folks?
As always, Steve, I have a couple. Thank you for getting
Sure.
back on regarding the IGT. I really appreciate that and letting us know about the incoming funding streams too, because that makes me feel better. I was curious when we're talking about the lab expenses related to COVID testing, are we using any of our COVID relief money to offset that, or can we use it for that purpose?
The best answer is to answer the second one is yes. Absolutely, we can use it. What'll happen is here in the next month or so, we'll file a report with Health and Human Services, and we'll show them what we've done with the funding. And one of the things we will be claiming absolutely is the cost of the testing supplies.
Okay.
So in a way, it's a covered expense. So it's a good way to look at it.
Okay. And then I guess my other question, I don't know if it's necessarily directed toward you, but I'm just wondering if there's any other equipment that we might foresee as possibly needing that might also fall under such category that we haven't looked at acquiring yet, that we might need to be spending the money on.
Jerry, are you referring to COVID related?
Yes, sorry, Ken.
Yeah, I'll let Sean speak to that. We've been having discussions about that, and I think he's got some thoughts on that.
Yeah, so anytime that we have a piece of equipment that we need or something that's going end of life, and we need to look at appropriating, we are taking a look at whether it passes the sniff test as it aligns itself with our COVID impact. That's sort of the first thing we do. Since the money's there, if we do need a piece of equipment, and we've been noodling on that for quite a bit, does it have an impact to our COVID preparedness or anything else? So it is always passed through that first, Jerry. I mean, I'd love to get equipment when, never waste a good crisis. Is that what the term is? But I think that we pass anything. Nothing's surfaced to date necessarily that we need to replace or that would be prudent to replace. I don't want it to be Christmas morning and think that it is Christmas morning for any reason whatsoever. But yes, as we look at equipment, we do talk about whether it is a COVID related expense or not.
Can you do that through the lens of being proactive?
I would like to do it through the lens of a crystal ball, so I know how long this is going to last. But I can tell you this, that the recent announcement that we are going to stay in a state of emergency preparedness through 2021, which is recently released, I would say that that's sort of the setting precedent for us to take a look at it, that COVID is sticking around and that a more proactive approach to some of this equipment might be something we can deal with. Once again, that's the government that has come forward and says 2021 looks like it's going to be a full COVID, if you will, emergency preparedness year. So certainly a proactive approach now that's been released. I think it was released last week, wasn't it?
Yeah.
We can certainly take a look at what's in the future and how it applies to this COVID issue. Definitely.
Okay, thank you.
Yeah. And so kind of dovetailing on that, Steve, do we anticipate at this time having to return any of the COVID relief monies in any of the categories? And you don't have to give me a hard answer. I'm just trying to get a feel for it.
Depends on how much equipment we want to buy.
Well, that's partly what I'm wondering.
I think what we'll do, the best way to answer that one, Jerry, is that we're going to, as quickly as possible, make a determination if there are dollars potentially at risk. And if they are, then we have some ideas about what we might be able to use that for. So there's always that possibility. Unfortunately, the guidance on the federal reporting is very weak right now. So we're not sure. We're not sure how they would go about taking back money necessarily, and where they're going with this. And we're just in a very unique situation where, with a few other small hospitals where we haven't been impacted to the point that others have, and then the amount of money we've received. So it's a good position to be in.
Okay, thank you. I appreciate that, Steve.
Great questions, though.
Okay, board members, any other questions? Okay, hearing none, I would ask for a motion to accept the financial report from Steve.
So
for
moved.
December. Jerry? Second?
Second.
Rich, second. Okay, Dr. Walls? Dr. Walls, can I have your vote?
Aye, sorry, I was having trouble hitting the mute button,
That's
unmute.
fine, thank you. Kristen?
Aye.
And Rich,
Aye.
Jerry,
Aye.
and I'll vote aye as well. Thank you, Steve. Appreciate that. The next item on our agenda is the board meeting dates for this next year, 2021. A list of meeting dates that, unless I missed something, reflects our regular meeting schedule, Thursdays, last Thursday of the month.
Ken, it looked like we needed to talk about rescheduling one of them because it fell, I think, on Thanksgiving,
Yes.
the one in November. Give me 2 seconds. I got to grab my calendar too.
It's crossed out on the
Looks like
itinerary here.
Thanksgiving.
Yeah, there is not one scheduled for November. I know last year we put it early December.
Right.
Yeah, we moved it to
had
the following week.
We had 2 in December.
So the first Thursday in December is what?
The second.
Just a second.
So we should make that December 2nd, just similar to what we did this year on the 3rd and the last date of the year. So are we going to do it December 2nd then instead of November 25?
Yes.
Makes sense to me.
So any other comments related to that?
I'll just make a motion to approve the board meeting dates with the November 25th meeting being pushed to December 2nd.
Okay, so Jerry Nielsen makes the motion to accept the schedule with the exception of, well, not with the exception, with the caveat that we move the November 25th meeting to December 2nd.
I'll
Okay,
second.
thank you. Dr. Walls,
Aye.
Rich,
Aye.
and Kristen,
Aye.
Jerry,
Aye.
and I will vote aye as well. Thank you for that. And that takes us over to the joint conference meeting dates. 4 meetings, March 11th, June 10th, September 9, and December 9. Okay. Okay, so typically we have different people come to different meetings. Am I correct in saying that?
Yes.
Okay. Volunteers here for the first one coming up this March 11th. Board members?
I can. This is Kristen.
Kristen, thank you. How about June 10th?
I can if others can. I'd prefer either the September or December dates. Rich, are you around in June?
I do my meeting in Ojai that week. I'm available in September, but I'm not in June.
I can do both. I don't mind.
I kind of lost track there. Kristen, you're talking about what date?
You were saying in June. What's the date in June?
Yeah, can you do that one as well?
Yeah. What was the date?
That is June 10th.
10th. Okay.
I have to tell you, I have a problem with Thursdays. I have class on those days from 11 in the morning until 2 o'clock. So I'm kind of out of contention for these meetings. So we still have needed representatives for September 9th and September 9th and December 9th.
I'll volunteer for September.
September,
So, and Ken, traditionally the chair goes to these, but I'm looking at my calendar. I should be able to work these in. I can attend instead of you if you want me
well,
to.
actually, the one I can attend is in June because school will be out at that time.
Okay, so do you want me to attend the March, September, December?
If you could, Kristen said she can do March.
Yeah, but we're supposed to have 2 there.
No,
Well, hey, Jerry,
Yes.
don't forget I attend because I'm a member of the medical staff.
Oh, I'm sorry.
So if you have 2, then I won't attend. That's not a big deal for me.
Okay, I'm sorry, Dr. Walls. I wasn't thinking about that.
Well, I don't mind. I don't have to go to all of them. It would be nice to get more board members into these things.
Yeah.
So let me go back over this. I've kind of lost track here.
Sorry, Ken.
Kristen, you're on March 11th, right? And Jerry, you're saying you can do that also?
You can slot me in wherever you guys need me. I'll make it work.
Well, I think where we need you is December 9th.
Okay. Then I will put that on my calendar.
Okay. And Kristen, you've asked, we had you identified for 2. I can do the June one if you'd prefer.
It doesn't matter. That's up to you.
Well, that's the only one I really am confident I can do. So why don't I put myself there?
Okay.
So as I have this now, Kristen on March 11th, myself on June 10th, Rich on September 9th, and Jerry on December 9th. Okay,
Can I make a comment, Ken?
yes.
The last paragraph there, it describes the committee. It's a rather casual committee, but I don't see in there where the CEO attends, and yet we expect the CEO to be at every meeting.
Can we add that to this language, Sean?
Yes, certainly.
I wonder, Dr. Walls, might this be written out in the med staff bylaws?
Yeah, actually it is, and it's directly from Title 22.
Yeah, Joanne, would you please take a look at joint conference committee out of the bylaws and make sure that we include language related to the CEO's presence? Great.
All right, so again, the schedule is March 11th. Kristen, June 10th, I will attend, September 9, Rich, and December 9, Jerry.
Got a question about clarification.
Okay.
Dr. Walls can attend the meeting of 2 board members there. He just will not act as a board member. Right? That's allowed.
I suppose.
I think technically speaking, Rich, but I think we've traditionally tried to avoid the appearance of there being, any sort of decision-making body in one place without it being a public meeting.
Well, if our goal is to have more board member involvement, the joint conference, we shouldn't let the fact that Dr. Walls would have to leave. I don't think he needs to. I don't think that Brown Act prohibits that.
Rich, are you volunteering to attend more than one meeting?
If I can, I would, sure.
Dr. Walls, what are your thoughts on this?
We've discussed it ad nauseum, and I don't think we've ever come up with a legal opinion. But I can just say that I think the idea is to encourage more board members. Although I will say this, since our medical staff has shrunk down to just 3 people, we have a hard time getting enough doctors to attend.
Right.
So I think we need to really try to do what we can to get the medical staff to attend these meetings. And I want to make sure everybody understands that this really is a requirement of Title 22.
Sean, do you have any thoughts on this? Just want to get everybody's guidance here.
I don't. I think what we need is revert back to the bylaws and make sure that we are, they're explicit. So I don't have a position at this point. I'd have to take a look at them, and I haven't read them anytime in the recent.
I'm assuming we can address the issue of multiple board members and take a look at those bylaws in advance of this March meeting that's coming up. So if that's the case, then we could carry this over.
Yeah, and since I'm here every day, Ken, I'll work with Sean to figure this out.
Okay.
Or Ken, we could probably move forward with what you've already outlined and then add additional
Right.
folks later on if we decide that that is an allowable step.
I'm okay with that. That would require a motion that we approve those board members for the dates identified here. and is subject to some additional changes at our next meeting.
I'll make a motion.
I'll second.
Jerry seconds. Dr. Walls?
Aye.
Okay, Rich?
Aye.
Okay, Jerry
Aye.
and Kristen?
Aye.
And I'll vote aye. Thank you. Okay, so that takes care of our action agenda. The informational items are HRG, and that brings us back to Steve.
Yeah. Okay, so we have the report from HRG for the month of December as well. And as you can see in tab G, that the AR days went up slightly. So this was one of those anomaly months where we had such a significant drop in the AR that we also had a movement in the average daily revenue. So the overall AR decreased over $300,000, but because of the average daily revenue, it was the days went up a little over one. December was the first month where our new agreement was in place, where there's the incentives and penalties. Because of the drop in revenue, the AR day penalties did not come into. We're not effective, if I guess lack of a better word. So they did not apply for this month. They missed all of the AR days greater than 90. So there was a 4% penalty for the month of December. The AR greater than 90 days is really the problem right now. The current stuff seems to be moving okay. They're within the target. So we are going to sit down with them weekly if we have to and go through in detail the greater than 90 days and why that just continues to sit out there. They've had very little movement on it. They do give some explanations. And I do understand that some of these insurance companies are just telling us to pound sand. So we have limited recourse or somewhat limited recourse with these payers to a point anyway. So we need to look at that. Also, the unbilled was high for December because of the COVID that was in the nursing home. Our outpatient charges to the residents was extremely high for the month, something we've never seen really, and that does not get billed until the month ends closed. So that was all reflected in the discharge, not final billed. So we missed the target there. Our revenue is growing into January. As a matter of fact, I think we have five patients on the floor today. But so we're not going to have the revenue issue. So all the measures should be in play, and we think we can also get our unbilled within our target. So this will be a very interesting. January will be a very interesting month for HRG and all that. So any questions or comments about that?
Questions from board members?
No, it'll just be interesting to see what comes out of January.
Yeah.
Mm-hmm.
What does a 4% penalty translate to, Steve?
For the month of December, their fee was just under $40,000, so it was about $1,300.
Okay. Thank you. Just curious.
Yeah, I mean it wasn't enough, but the maximum they could get is an 18% penalty, and right now they're taking a hard look at that. So that would be a little more of a issue for them, I guess, is the best way to say it.
All right. Other questions?
Hey, Ken.
Yeah.
Ken, I'm sorry. During my presentation, the bank signature cards are ready to go at Plumas Bank. Are you in town tomorrow? Are you available?
Yeah, I am in town tomorrow, but not until late afternoon. I have classes all morning.
Okay.
I'll try to get over there tomorrow.
Okay, if you can just give us a call when you're available to do that. They need you to go there in person. Everyone else, we can just sign the cards in the office. So just let us know and we'll make arrangements for that.
I'll be at a class around 2:30, so that'll be on my agenda then.
Okay,
Okay, thanks.
thank you.
Okay, so that takes us up to committee updates, Strategic Planning Committee, and I'm assuming that's you, Sean?
Yeah, it's going to be part of my CEO report, but I can tell you that, let me just go ahead and skip to that, and I can skip it in the CEO report.
Okay.
We have met with Aspen, so we are resurrecting and moving forward on our strategic planning. We met with the architects. I've met with Moneth, Lance Moneth, several times around the plot and the CEQA requirements around the plot. So we are moving forward. There's been some interesting conversation around space use, not only in the clinic here from strategic planning, but the new building itself, the new hospital. So we are kicking that off. There's just gonna be a lot going on in 2021 as it pertains to design, build, build, design, starting to work through our total square footage and which is OSHPD 1 and which is OSHPD 2 and 3, because clearly OSHPD 1 is extremely expensive. So we want to take a look at how we can minimize that space and still create a good workflow in and out of the building, in and out for patients and for staff. So that's happening. ASA is doing some research for us on some things that we requested in our last meeting. We are going to be spinning up the strategic plan as it relates to some of the detail work that each independent department is going to be moving through and designing their space. Strategic planning is also considering repurposing of the existing building. We're already starting to look at options about how we repurpose the existing hospital, how we are repurposing certain spaces within the clinic, how we're going to use them. That we have some upstairs space. So we're taking a lot of things into consideration as it pertains to what is our short-term strategic planning, new building use of space, existing use of space, and then repurposing the space once we get over to the new building. There are some really interesting conversations I'm excited to share with the board as it pertains to the design of the new building. Some things that are happening out in the construction world that are revolutionizing the way that we look at building new hospitals, and I'm very curious about it. So we have ASA working in that regard. There is a
quick question, Sean. When might we get a glimpse of that?
A glimpse of the new hospital?
Well, just some of the design ideas, I guess, and stuff. Yeah.
When they're obviously right now we just have a bunch of little square boxes.
Yeah.
But I'd like to put some square boxes with some, I don't know, put some little bed icons in there and stuff so that you can take a look. It's going to be a little bit still, but it is going forward. We are going to be moving forward. I'm happy to show you at any phase, at any stretch, where we are. You can just, by all means, just ask for it and we'll share it with you. And start sharing it openly with the community once we get something that's a little more visible, something that we actually can put our hands around and our minds around. We've got some good things going on with Collins, the land. Once again, Lance Moneth is running that, moving into CEQA, trying to get that all situated so that we can start being shovel ready when we are ready. Some other things that need to be brought to the board. I'm going to be seeking, I am seeking proposals actually for a design and construction project manager that is on our team, that is for us. I have built hospitals before in the past, and I found that the greatest resource that we could possibly have is somebody who has built hospitals in the past, has an engineering background and a project management background to keep everything flowing on track. This is a huge, it's just a lot of work, and there's a lot of intricacies to this. So I'm going to be asking the board, bringing to the board a selection for a project manager that is going to be on our side, and they'll work directly with the design, construction when we get there, and just everything. They incorporate everything in a nice project plan with milestones, so it's nice and methodical. We just want to step through this and not forget anything. The biggest thing for them is they try to avoid us from change management or change plans, which cost a lot of money. So we would try to get ahead of that. So I'm going to ask the board for approval to move forward on that project manager, probably in the next meeting. We are reassessing the Whipfly market study right now. Steve's been working with Whipfly to take a look at shrinking or expanding or just changing our primary service area. So we have a better understanding of the financials and what we're going to be up against as far as a debt service and things to that effect. What sort of things are going to be needed in the future? We want to build, once again, you don't hit the puck where the player is, right? The old idea is you hit the puck where the player is going to be. So we're really trying to think through what the community is going to look like in the future, what we need to build for. We're reactivating internal strategic plans, planning committees. We've reactivated Aspen Street. We're finalizing plot activities, and we are going to be considering starting to look at our funding options. I've asked Steve, and we'll be moving into that dialogue more, where we take a look at our funding options out there. And this is going to be, that's a lot of work, and Steve's going to be saddled with that. So yay, go Steve. But there's a lot going on in strategic planning, and it's going to get busier.
And where's the contract now for the land, Sean?
So Lance Monmouth, so we are in plot. Let me grab a document really quick here while I'm speaking to you. We're working right now on entitlements and CEQA. So it's still going to be a process of about 6 to 9 months.
Okay.
But if we're doing these things parallel, when we're doing design and the parallel process of the land, by the time we're ready to dig dirt, we should be taken care of in that regard.
Okay. Can you remind me what the CEQA piece is exactly?
The CEQA is environmental impact. So
Okay.
it's the environmental impact. It's geotechnical. It talks about, we've got a creek over here, and they've got to make sure that we don't have an impact to the environment. Some of it's going to be easements and how that impacts certain traffic patterns and things like that. So it's a lot
Okay.
of the work related to inflow, outflow, and the environment.
I guess I misunderstood because I thought that was taken care of before the contract was hashed out with Collins, but that's not the case.
Well, maybe I'm misspeaking. Steve, you want to jump in here about the CEQA pieces that we're missing? Do you have an idea? Can you help? Steve, anything?
Maybe he stepped away.
Possibly. I could provide more information for you, Jerry. CEQA is a little foreign to me. I'm not a developer, but I know that if you don't go through CEQA, it's going to be a problem. And it's
Yeah, I just remember talking about environmental impact reports, and I could have swore we had that part done, but I guess perhaps not.
I've seen the geo, but I don't know that I've seen the geo report as it relates to flood zone designations and on the new site, but I don't know that satisfies CEQA.
Okay.
I'll talk to this. Go ahead.
This is Linda. Maybe I can help with that a little bit. Jerry, the only thing that we did with that property is we had the geotechnical folks come up and do a quick survey of that property to make sure it wasn't swamp land or the creek wouldn't impede too far, so that we could be assured that where we were thinking of building was adequate and that we didn't need to change locations for the property that we wanted to acquire. Other than that, we still have to go through the environmental impact reports, and we need to have a full geotechnical survey for earthquake and land movement.
Okay, thank you, Linda. So then, so is Collins holding off signing off on the contract until we get those studies done?
They're ready. The process, though, going through the process takes to 6 to 9 months. They're ready, though. Collins has been very good at moving things forward. So it's just a matter of making sure everything's lined up. And I can get more information from Lance, because I basically tasked him with managing this all the way through to fruition, to completion in a parallel process.
Okay.
Okay.
All right, thank you. Thanks, Linda.
Thank you, Linda. It's strategic planning, but I want to talk about existing facilities upgrades. We've been going through a process of taking.
Can we just, one thing before we get away from strategic planning? Strategic planning is an official committee of the board. And I don't think we have representatives assigned presently.
Of the board and the community as well, if I'm not mistaken.
We have added community members, but it is in our bylaws, I believe, where we have a strategic planning committee. And I don't think it's active. I was on it in the past.
So Rich, I guess you're referring to our turning over to the new year with needing to have those appointed by Ken?
I think Ken should, if I'm correct, I think Ken should appoint, we had 2 board members be on the strategic planning committee.
Let's appreciate that comment. Let's take a look at the language in the bylaws and come back to it next week then.
Yep, and we're,
Carry
happy.
this over as an action item for appointments if it's consistent with the,
I think we had 2 committees, strategic planning and bylaws.
okay.
And Jerry may know better than I when
Well,
we,
bylaws is done.
Right.
Yeah, so,
I just like to see the board members be involved in strategic planning.
Yep, happy to have you. Absolutely.
so
And you guys, hi, I'm sorry, this is Steve. And Rich, you and Jerry were involved in the initial rollout of the Lipsley and the Aspen study. And then we took a break from it. But you 2 guys were in those meetings that we had with the consultants.
Yeah, I just assumed, Rich, that they were kind of trying to get up to speed and button some things down before pulling us in, but I may have
Yeah.
misunderstood.
I'm not being critical of what's going on. I'm just,
No.
Sean isn't aware that we had this committee. So,
That was just an agenda item, but if we have a committee, and I mean, I'm more than happy to get some board members involved, especially as our project manager starts to really push on it and move it forward and start setting regular agendized meetings and things like that. I welcome the board, absolutely.
yeah, I
And
think that,
ultimately the community as well, ultimately.
yeah, including Sherry Thrall,
Yeah,
who
we
could-
need Jerry to.
who could help get us through the county very quickly.
Right, there we go. Very good. Anyway, it's off to the races. It is going to be happening. While we're on it, if I could just transition, strategic planning also includes existing facility upgrades. So if the wind's at our back, I mean, if everything just works perfectly for us, we're looking at about 4.5 years. That's about what it takes, 4 to 4.5 years. That's with the wind at our back and no big issues related to the new building. So we've got some things that we need to do, both from a public relations perspective and quite frankly, from just the facilities maintenance perspective that we're batting around with the existing site. Some of those, the hospital, the new roof, that has already been approved. It's been OSHPD approved and such. We received 1 bid, and Linda, keep me honest here. We received 1 bid, I believe, for the roof. I would like to take it to bid again since we're looking at a potential spring work job. I think we have time to go to bid and see if we can get some other folks in there and rough it up a little bit, see if we can get a good price and such. So that's going forward. Linda, anything on that? Linda? Okay. We have a couple of drawings from Aspen about the front of the building, not only with the facade being maybe new paint or new siding, but there's a vestibule, a possible vestibule, a drive-through vestibule that is covered by the weather, that covers people from the weather, that we're taking a look at, including some additions of some ADA bathrooms and things in the front. Once again, this is we've asked Aspen to go away and provide us some plans. We've taken the first step where we're actually having that area surveyed, because we're going to have some changes to our parking lot that may be in some intrusion in the parking lot. So we're having it surveyed. I've approved the survey so that we can at least get off to the races and get the design moving on the vestibule. That's going to change the characteristics of the building. And if it doesn't come in at a ridiculous cost, I think it's something that's worth looking at. Other things, siding and painting, ambulance ER covered carport. I'm not sure if it's been spoken to in the board before, but in the back, we're looking at putting a carport in for the ambulance to be out of the weather, so that patients are out of the weather when they're being delivered to the back door. Something we're taking a look at. Security cameras. Under Title 22, we have required security cameras over our Pyxis, our drug dispensing unit. So while we're looking at that, we're also looking at possibly putting some security cameras out into our ingress-egress zones so that we understand what's happening outside. That's something that provides the staff some security awareness. And we're taking a look at that. PG&E shore power for the MRI unit. So the MRI unit that comes out here, we're currently leasing, I believe, the generator. MRIs don't like generators. I can assure you, I've been doing it a long time. They don't like it. So we do have the approval for the PG&E shore power to be pulled into that zone so that the trailer can have proper power. And that would also afford my ability to discuss the MRI company with a better unit, because they don't want to fry a unit. It's a good unit, don't get me wrong, but there's better units they have in service. And I could speak to them about that kind of a rotation through here. They just won't put it on a generator at this point. We're planning the space use in the clinic upstairs and downstairs. I talked about that. Clinic carpet replacement, it's been approved. We'd like to get the carpet replaced. And the remodel of the Reynolds house, which is already pre-planned, and that's actually going to start in about 15 days. So that's pretty much it, what it relates to old building, repurposing, new hospital, in a nutshell.
Now, Sean, and the board can correct me if I'm wrong, but didn't we have an ambulance covered carport that we had to remove because of seismic requirements or something along those lines?
Yes, we used to. We used to have one, and it was taken down, and I've never really understood this is not Sean, this is Dr. Walls. I've never really understood the reason why it had to come down. But you're right, we did have a place for the ambulance to pull up and offload patients so that they were not in the weather.
Yeah. Linda, if you're still on, I don't know if you want to take a minute to just add some history there, why we had to take it down. I have no idea. And if you're not on, then we'll.
Yeah, I don't see her. There was some OSHPD related reason.
But someone
for it.
just unmuted me.
Oh,
There we go. I couldn't unmute myself for some reason. So, yes, we did have to take that carport down. There were a couple of issues with the carport. The original structure that was put up there was not made for the new style gurneys coming out of ambulances. So the ambulance really couldn't get under there anymore and offload to the dock. So basically what that carport was doing for us, it was covering most of the walkway to the CT scanner, and it was affording maintenance the opportunity to be able to park our grounds vehicles underneath the carport where the ambulances used to go. The other issue was there was no seismic certification on that particular carport, and with it still attached to the hospital, it brought the hospital down to SPC 1, and the standard was we had to bring it up to structural category number 2. So in order to do that, and in order to obtain our extension for the building of a new hospital from OSHPD, we had to remove that carport. That's why the carport went away.
thank you, Linda.
Linda's our historian. Thank you, Linda. That's great.
I did
You're
have
welcome.
a quick question, if I can, about the shore power for the MRI trailer. Given that we have power outages because of storms up here sometimes, is there an MRI unit that would be compatible with a generator?
They're all compatible, but the generator can provide the power to the MRI. The issue is that an MRI is a sensitive piece of equipment, computer-wise, and because it has what they call a Gauss field, a magnetic Gauss field. And so you don't want to upset the magnet. You don't want to upset the computer system. So they don't want to risk putting a newer unit on that. They'll basically put an older one on there, and they're happy with that. They will run on generator power, although they'll tell you they don't like to do it.
Okay.
They don't like it.
I think, aren't we getting either a grant money or a reduced cost to implement that shore power line?
Steve, can you tell me? I know that's been approved. I don't have the history. Or Linda?
This is
Go ahead,
Steve.
Steve.
Yeah, we got a reasonably good deal with PG&E. It's going to be, probably in the low 20,000 to get the whole thing run in there. So that was a fairly reasonable, at least in our mind, cost to bring the necessary power in there.
Thank you, Steve.
And that's paid for already, so we're waiting on them.
Any other questions about strategic planning? Okay, thank you. Oh, I guess I'm up again, right? CEO
Yeah, you
report.
are.
Okay,
Oh,
we'll just keep going. We'll just keep going. Okay. The COVID-19 update, let's talk about that. It is, suffice to say, it has been a whirlwind for the last 6 weeks or so as it relates to COVID. Right now, the current status at Seneca is that we are a COVID-free environment. We have no staff that are there. We are open in all elements of the facility. And as Steve mentioned earlier, our census is up. So I'm pleased that we were able to do a really good job of containment and moving beyond it. Great job of surveillance. I mean, the Stephanie and the infection nurse and everyone's done such a good job of surveillance with the staff and constantly reiterating the CDC guidelines and PPE and doff and donning. So there has been some really good structure by the nursing staff and in guiding and helping work through COVID and in preparation for. So I'm very pleased with that. We are working constantly with the county, as is all hospitals within the county, on getting vaccine to arms. So that is our big push right now. We are following the tier guidelines. And the bottom line is that when we get it, we will put it in arms. We have the ability to do that, and we are wanting to do that. It looks like it's opening up a little bit, which is good. I wrote the state personally. I reached out to the state and said, hey, remember us up here in the north, we need it too. So it looks good on that front. Really, the quarterback on this is going to be the public health agency, and we're just following guidelines and ready to assist with the vaccinations whenever possible. There will be some more testing that's coming out from the county, mass testing, and we will accommodate that as well. We're remaining diligent. Yes, go ahead.
Sorry, let me interrupt you just for a quick second there.
Sure.
When we're talking about the vaccines, I know there's been some reported challenges with getting some of the healthcare workers in other areas their second dose of their vaccination. So I'm wondering what % of our staff have received their full course of vaccination, if we have a feel for that, of those who want to be vaccinated.
Right. So Karen, you may have more input on this, unless I don't think Stephanie's on. I can tell you that we did receive a second Pfizer. And I just inquired today on our COVID call this morning, whether or not we're getting our second Moderna for the folks that got that. And I believe the answer was yes, and that's good because that would be me. So Linda, do you want to jump in, or Karen?
Hi, Sean. Go ahead, Karen.
I'm sorry, was there some confusion here? Sean, were you asking for feedback from Karen or?
Well, Karen, but I just got a call from, I guess Stephanie is listening, and we have had full dose, 48 full doses. So we've completed 48 of the secondaries. And we are expecting another, I think Moderna is coming in, and then we'll be able to do second doses of Moderna.
Okay, so about half maybe of our staff so far have full.
Sure. Sorry,
It's okay. I'm just trying to get a feel for whether the challenges that I'm hearing elsewhere are also happening at our facility, and it sounds like they are.
*6, Stephanie. *6 to unmute yourself. She wants to answer your question.
Okay, thank you, Stephanie.
Hi, can you hear
There
me?
she is.
Yes.
Thank you.
Sorry. Our first round of vaccines for our staff were Pfizer, and everyone that received a Pfizer vaccine has been fully vaccinated. Next week, I believe on Tuesday, I will have the remaining second dose for our staff members and a few community members, like specialty clinics, like the optometrist office, a few of our hospice employees, and other people that fell within the tier category at that time. We will have their second doses available. It is a challenge. We are running into the same issues with most other places that are having difficulty with vaccines. The main issue really is that larger hospital corporations like Sutter, Dignity, Kaiser have the ability to get larger allocations, and they're holding on to them. So the state is getting now a third-party resource that's going to help with, in conjunction with California Hospital Association, to help with even playing the field for disbursements of vaccines. I did get notification from Public Health today that CCC, so California Corrections Department, has additional doses that either they have or people are not using. So Plumas County should be getting about additional 400 doses from 2 different prison systems. The issue is us trying to get the doses physically is the next challenge, but we do have access and they're using the resources as best as they can.
Great, thank you for that, Stephanie. I appreciate the update.
Thank you, Stephanie. Stephanie, thank you very much. So I'm glad you jumped on because she's got it in her pocket, all the information, staying on it. Thank you. Any other questions around COVID? It's something that we're constantly aware of and meeting every morning about. So anything else? Oh, okay. Physician and mid-level recruitment. If you take a look at attachment A, so we sent out a community survey, and we're doing a lot of surveying right now. We're doing community, we're doing staff. There's a lot going on as it's just understanding where we stand in the world and where we are. And so one of the things that came back on the attachment A, which was really interesting, is when we asked the question to the community, what is the most problematic aspect of quality of care delivered by the hospital? Pretty much overwhelmingly at about 55% was physician recruitment and retention. And that is an issue, and we are working on it. I just signed a contract with a company that I used to use that was very good at placing physicians by the name of Medicus. They have a very interesting methodology and, quite frankly, a huge database. And they're really good at placing, especially in rural healthcare. I've also been reaching out to physicians of mine that are circulating that we are looking. So I'm doing not only my little black book, but we're working with a company that has a pretty good track record of being able to place. The big thing is that to profile us is the biggest issue. They're going to come up here and profile us. I mean, they've never, when you look at us on a map, you see an hour and a half from Chico, but what you don't get is who we are about. So this company takes a great interest in what are we about? What is our community? What is our culture? Look at the beauty of the area, what's available. And they really use that to try to fine tune physicians to come up here and take a look. And in a very honest way, this is what the lifestyle looks like. You know, you're not going to run down to Costco at 9 o'clock at night. It's just not going to happen. But as long as that is out there and that's part of our profile, they have a very good ability to hone down and fill that funnel with folks that are looking for that type of thing. And then we have the ability to really take a look at what is the best fit for now and in the future going forward. So I'm pretty excited about that. We're looking right now, currently we put in two search requirements. One is for a family practice, family medicine. And I've asked preferably that this person can do women's health. You know, I think that's something that we're lacking. I'd like to see them be able to have a history of women's health. So there's that, and a mid-level, another mid-level that can also pick up primary care. So that is, we're doing that. And of course, I'm putting it out there. We've been doing a little job of putting it on LinkedIn. I mean, Chelsea's been out there. Chelsea, our social media is crazy right now. It's insane. So good job just putting it out there. I'll move past existing facilities, strategic planning. Let's talk about operations. So a lot of things in operations that are being addressed and being taken care of. Patient transfers is a big one. I've met with the chiefs of both Peninsula and Chester Fire. We are going to be getting into, and Royce, you know, and then our ED to talk about our interfacilities transfer capability. It has been a bugaboo. I'll just put that. That's a word we don't use it very often, but we have got to have the ability as a critical access hospital to have reliable, quick interfacilities transfer capability, whether it's ground or air. I'm working on the air piece of it, but we're going to be working with our EMS providers and talking about how we can do this better. There's been some really interesting things that the fire chief, that Brian has brought forward. I want to explore a little bit. So that's a big one for us, something we're really focusing on. Information technology, and when I say information technology, I'm going to take away from the applications layer and move into our infrastructure. We have been using a company by the name of CSI, and I'm a little bit underwhelmed, to be honest with you. So we have gone to, worked out, we've met with 4 ITs, both managed services and companies that are just infrastructure, pure hardcore servers and security and things, wide area network, local area network. We've met with 4. We're going to narrow the gap, and I hope to have one under contract by next month. To do initial assessment, optimization, and then managed services so that we can take some pressure off of TK and the team to focus more on especially our EHR and some of the things that we've got going there. So that's moving forward. Any questions so far? I'll pause for just a moment.
Mine was just on the instrument landing. Where are we at with that, or was that all completed? And is that basically for when the weather is bad that they're able to get in here? But that has not been completed, is that correct?
It is with the FAA, and who knows where it goes when it's there. It is with them, and that is the final step. So the instrument approach procedure has been flown with an FAA examiner in there, so it's been approved. So it is ready to publish. We just have to get through the bureaucratic steps of the Federal Aviation Administration, and then we're going. And then we'll reach out to all of our providers, all of our AirVac providers, to talk about the instrument approach, because they too have requirements. They have requirements around their aircraft and the capabilities of their aircraft and their pilots. And we just want to make sure that they know we have it and that they are willing to adjust and to accommodate us. So just some conversations to have, professional conversations around their ability to service us.
And Sean, do we need any more letters of support from groups in order to help make this move forward quicker, or is there pretty much no moving it quicker at this point?
The letters of support from the hospital and EMS, which did go forward, our fire, were huge, because they see us as people who aren't, we don't have a profit margin, we don't have a profit mind around it. It is really services. So I think we've circled the wagons, Jerry, with the FAA, done everything we can. It's just a matter of their process, getting it through the process. Okay.
Thank you.
I will report when I get an update, though. We are going to be doing a massive facility cleanup. That's part of our operations. We are going to clean house. Spring cleaning, winter cleaning, it doesn't make any difference. We have a lot of stuff. We hang on to a lot of things. So an email went out just this morning from Linda McCurdy to talk about cleaning up our upper area of the clinic. We're going to wipe that out. If it is not usable, if we haven't used it in a year and it doesn't have any value and it's not on the books and we're not going to use it in the future, we're getting rid of it. Either repurpose it, throw it away, or do something with it. But we are going to be doing a massive cleanup, not just upstairs, but we're talking about the train car and just moving things around, where taking a look at our space once we've cleared out, what kind of space do we actually have for supplies, for disaster recovery supplies and such. I think that we have a lot more than we think. And then just the general cleanup overall. You know, clutter is going away. I personally have an issue with anything taped to a wall. So it's little things like that that we're going to work on. It's just an aesthetic to the organization. It makes it just look cleaner and more professional. So big movement through. That's going to be a constant push. Process improvement, we're going to be working through processes, and I'm going to be asking each manager. We have our first managers meeting coming up Tuesday to select the 5 processes within their divisions and work on a process improvement strategy. Pick ones that are really going to make a difference in the organization and work through them. And there's a process to do that. So working on process improvement, that will be an ongoing thing.
And are we helping train our managers? And I'm sure they're familiar with the concepts, but training in this area is always extremely helpful in order to be the most strategic about what you choose to improve as far as processes go.
Yes, it's true. And there's one person I have in mind that is a process improvement, workflow improvement person and trains through the processes. I haven't had a conversation with her yet. But I just want to introduce the concept of constant process improvement. It never stops. It's constant. When you've got one locked and everyone's coloring in the lines, we move to the next one, and then the next one. It's iterative, but it's forever. So we want to get into that muscle memory of constantly looking for ways to improve our process and build that muscle memory. So there's that. Patient experience. I want to bring, we use a thing called NRC, patient experience. So if you've ever been seen here, you'll get a call or a text. We're going to be moving text and such. I think that attachment B is really interesting. It talks about us. Attachment B is how we compare in our comparative group, rural hospitals, same bed size, same basic services, how we compare up against the 75th percentile, or what we call top quartile of the NRC work. And if you can tell here, we have some work to do.
And Sean, we're the blue line, right?
I have to look on something that has color. We are the blue line.
Okay.
Yes. And I'm sorry, I didn't even, my axis, I'm sorry, I forgot to name it. So we're the blue line, and NRC 75th percentile or top quartile is the orange. This is something that we're going to be working toward, and this has everything to do with the patient experience. Everything from how they were greeted to were they communicated with? Did they understand what was going on when they left and such? This is really about changing the way that we deliver the care to our community in a concierge manner. We're going to chase that 75th percentile, and I will be showing month after month. This is going to be a standing graph as we start to move it This will be a standing graph. I want it published to the community. I want to see the board to see it, that we are going to be making strides to that 25th, that top quartile. So
Right, is that the target, Sean? I'm sorry, are we gonna set targets, milestones, I mean, on all these indicators?
our walk is the top quartile. That's our walk. And we're not going to get there overnight. This is something that this will be working through, but I want to see that blue line inching closer and closer and closer to that top quartile. And when we hit top quartile, I'm afraid we're not done. That's just the top 25%. We need to start striving with the top decile.
Yeah.
And keep moving that. This is really, NRC is really a tool that we have to judge how we're performing in the community and what the community's saying about us, because this is real time. It is also used, go ahead.
I'm sorry, Sean, I'm just gonna say, this really dovetails with the whole idea of process improvement. Empowering people to look for ways to improve processes.
Yep. It has to do with cultural shift, reassessing how we do our work. What is the sacred work in healthcare? How do our patients see us? How are we taking care of them? So it's a lot of things. It's process, it's concierge, hospitality back into hospital type of things, moving that up. So constantly stretching ourselves to get there. We're also going to be looking, NRC has what we call real-time analytics. In other words, when you deliver a message to us through our survey, it shows up, okay? And we need to address anything below a 7 immediately. It's immediately. It's not a week from now or 2 weeks from now. It's when we see something where somebody's got an issue, it is going to be our job, all of us, managers, everybody, to address it as it comes up, and then bring it forward to the managers meeting to say, we seem to have a trend here, or it's just trending. It's making sure we have awareness of what's going on and making sure that we are doing recovery.
Yeah, it's interesting, this graph that you provided, because we kind of follow the same general line as the one above, but there are places where we definitely have larger gaps than
Yep.
other places.
Yep.
So that's interesting.
The family was involved in the visit. That's dropped quite a bit. That's just COVID. Unfortunately, we've not been able to get family involved, the visiting and such. But illness prevention. Let's be more proactive about how we deal with preventative disease processes, and things like that. So I just want to show you this graph that we're going to be chasing the top quartile. That's going to be our goal, to move that graph up. And we'll be reporting it regularly.
Will this come just in the form of a quality improvement report or quality assurance report, or how will
Well,
this
the indicators are, that they're not necessarily aligned with quality improvement. This is more patient satisfaction, but certainly some of these things move the ball in quality as well.
Yeah.
It moves the ball in quality. So yes, they're all encompassing, but this is an important thing for us. It's an important thing for this organization. It's an important thing for the community. So we're going to chase it. Training classes. I'm all about training. So I've worked with the Sacramento State Paramedic Program. I have a good relationship with them, and we are going to be hosting, including for EMS, ACLS, PALS, which is Pediatric Advanced Life Support, BLS. We're going to be hosting those training sessions here.
And possibly ATLS also?
ATLS, AMLS, those.
What's AMLS? I'm sorry, I don't. That one's
Advanced
not
Medical Life Support.
Okay.
ATLS, is that Advanced Trauma Life Support?
Yes.
Okay. Yeah, I mean, those types of things are available to us, and we can't train enough. Bottom line is, we just can't. Along with that, providing these training, we are also going to be inducing mock codes. We're going to be bringing those back in, and mock codes where we actually have the ability to be assessed for how we deliver it, building once again that muscle memory back in. It's one thing when you're a facility that sees a code once a week or twice a week. We don't. So you practice, you play like you practice, and you practice like you play. So we're going to start practicing, and I think it's exciting. The staff have made it very well known to me that training has been something that's been gone for a long time, and we're going to bring it back. So good stuff happening. I talked about the community internal, the community survey. I can tell you we had 268 responses, which put this well right in the validity. It was perfect validity to make this a valid survey. So I was really pleased with the responses that came out of the community survey. It does have a validity statistic to it, which is good. We're also doing an internal satisfaction survey or an internal survey for the staff with a lot of the same questions. So it's going to be interesting when we get that and how they compare. You know, how we see ourselves versus how the community sees us. I want those to be well aligned. So that's going out, I believe, on Monday. Chelsea, are you on? Can you speak to that? I think we're going out on Monday for that.
That survey actually is ready to go out tomorrow.
Okay. So we'll start collecting internal data as well. It does have a few internal specific questions that we're curious about, but a lot of it is duplicative.
How frequently are we anticipating we're going to repeat these surveys?
Yeah, that's my question too, Sean.
Hadn't thought about that, but because it's like Christmas morning. I can't wait to see the first pass. But I think as the culture shifts, I think that we need to continually survey.
Yeah.
I would agree. I didn't know if you were thinking quarterly, biannually, annually.
I'm thinking at best twice a year. You know, I think that we need to provide time for our transition, for our shift.
You know, part of why I'm asking is because right now a lot of the results I'm assuming we're getting from the community are going to be folks that are perhaps here year round. I think we need to be capturing folks that are only here part of the year as well, and thinking about how we can kind of reach out and encompass those folks in our community engagement, I think is important also.
Yep, Chelsea, we'll talk about that. I think the one question I really want to ask is, did you know we had a hospital? Do you know that you're visiting that we have a clinic and hospital? And I think that's going to be a curious question.
Yeah.
I think it's a viable question though, because I've talked to people up here who aren't aware that there's a hospital or a clinic. So.
Correct. And we need to, and that's part of our public relations and marketing is let's understand that the brand has to be out there, that we've got to get that out there and be noticed.
And it may be also a point of signage, because we don't really have a whole lot of signage from the main drag that people notice unless they're in an emergency and are looking for that H symbol.
Absolutely. Yeah, the little tiny H.
Yeah.
Well, Chelsea said she's going to put me in a sandwich sign and make me walk up and down Main Street. So
there you go.
I'm good. Whatever I have to do. But she threatened that. But no, signage is a big thing. Community awareness, visitor awareness, big piece. You know, I'd like to get out to all the property managers and the VRBOs and stuff that they have our pamphlet in there, you know, that's sitting in the rental.
And places like Lassen Park, I mean, visitors who come there should know that there's a nearby hospital they can go to or a clinic if they have something come up during their visit.
Yeah, we want to put a box over by the Pacific Crest Trail too, just a box there, you know, when you come through there, it's just a big H sign says that way.
Yep.
Blisters and your ticks, but we'll take care of it. Anyway, lots to come there. Community outreach and communication. I can't say enough about Chelsea. If you haven't noticed, if you're not a social media person, I'm not really, but we are active in social media right now. We are going to be proactive as an organization in the social media platforms. We've moved into Twitter. We have Facebook, Twitter, LinkedIn, Instagram, and of course, our website's getting a little uplift here. We're working on some things to make it flow better. To just create a different experience on our website as well. So I know that Chelsea's working on it. Chelsea, do you want to speak to this at all? You've done a great job so far.
Sure. So yeah, like Sean said, we are active with all our social media, our website. We are actively participating in the town chatter that goes out once a week. So we are just slowly spreading the word to the community about what's going on. And then scheduling different things like, did you know that you can get this done at Seneca, things like that. And the website, we're making it more user friendly. So today we just put up an online application so people can fill it out digitally, as well as information on how to log in to pay your bill online, things like that.
I've been seeing a lot of those communications kind of in various areas, including I saw a coloring contest through like the school district, and I'm very excited about this, and it makes me happy every time I see something like that come out. So I appreciate the efforts that are going into the outreach.
Great, and then that's going to be, just the board knows, that is going to be a constant drumbeat. That's not something we just we do when we wants to say something. It's a constant drumbeat. So pretty excited about that. Did everybody freeze? Did I freeze?
Oh, you're good.
Am I frozen?
You're good.
We can hear you and see you, I don't think.
Hello?
Did we lose Sean?
Can everybody hear me? Anybody?
I can hear you, Sean.
I can hear.
Maybe we can send him a chat.
Okay, if you can hear me, Chelsea says that you can hear me. You
Yes.
can't see me. That's all I have. That's my report. I can't hear anybody. It looks like I froze up completely. So that's the report.
Is your, oh boy.
You can see me
Um,
and hear me.
Yes, we can see
Thanks,
you,
Kristen.
Sean.
Okay, I'm done because I'm frozen up here.
Okay, all right. That would move us. Thank you, Sean. I know you probably can't hear. Not sure what the issue is there. TK, do you have any proposed solutions? Because
I'm getting all these texts, so if you can hear me and see me, I'm finished. I'm going to try to reboot the system and come back on.
Jan, there's a few people that I think because of the weather that have had some session disconnects. If they log off and log back on, I can let them back into the meeting. I've been doing that via text with a few of the participants along the
Well,
course.
I anticipate that we will need Sean in the closed session, so that's what's my concern.
Okay, yeah, I was in the midst of texting him to request him to log off and log back on.
Okay, so I'm going to move on from the CEO report to item number 14, departmental issues reports. We had 3 reports submitted, one from Chelsea on compliance and then another one from TK on the IT stuff, and one from Jim Kooiman, HR Director on Human Resources. I'm not sure who's still with us and who's not. But board members, do you have questions related to any of those reports that have been submitted?
This is Jerry. I was just wondering if Chelsea happened to be on.
Chelsea, are you with us?
Hi, Jerry, can you hear me?
I can. Thank you, Chelsea.
Hi.
I appreciate your write-up. It's very thorough, as always. And I just,
Of course, thank you.
yeah, no, and I greatly appreciate it. And it allows me to kind of look into it to ask you some more questions, which I appreciate.
Of course.
I was just curious, we've been talking about the charge master, and I guess I'm wondering how involved our HRG is with, or has to be with the charge master piece, because I think I saw it mentioned here.
Yes, we just decided that we would have our HRG specialist, I believe is the title, step in and help take over, because they will need to, I can't think of the term. Is Steve still on?
Yep, hello. So I'm not sure where you're going with this, Jerry, but we did have a full review. HRG does a full review of our charge master every year, and we've made the recommended changes. And as far as we know right now and feel that we have a 2021 compliant charge master.
Okay, so we've taken care of the duplicate items that we were seeing in our charge master.
Well, it depends what you're talking about. Duplicate items. There was an issue with the ABNs where different items had the same CPT code, and so when we entered the CPT code, it could pull up the same things. We continue to work on that one, but that's just allows our ability to do an ABN.
And I think my concern was more around, and maybe I misunderstood, but it was more around if we had a particular item that we were charging for, but that we were charging different amounts against. So
yeah, again, I think that relates to the whole ABN thing where we pull up a CPT and we do, a doctor writes an order and the patient presents, the registrar puts in the CPT code, quotes them a price, and then the bill goes through and it's a different item under that same CPT code and the charge comes out differently. So
We're still cleaning
that's
that
just
up.
something. Yeah, that's just a hard workaround because they do have there's charge items that are properly listed with the same CPT code. I know we're working on trying to do something with that.
Okay, thank you. And then I guess my other question is kind of a general question regarding the charge master. I mean, how do we decide how much is the right amount for any particular item on our charge master?
Well, theoretically, there's markups for different services. So when you're doing pricing an item, you would mark it up 5 times Medicare or something like that. But we really haven't added too many items since I've been around, and since I've been here, we've not adjusted our prices because we think our prices might already be in the higher range. So.
Okay, and that's partly why I was asking, because I thought I saw somewhere recently that they're going to start requiring even more transparency in terms of individual pricing for particular items for patients. And so I didn't know how that was going to possibly impact us and if we needed to do another review of what our pricing was. You don't have to answer that now.
That's a two-part question. And the first part is that price transparency is a CMS mandate, and what they actually do is they want to be able to drill down to a patient responsibility. So if your contract pays this amount, here's what your responsibilities be. So it's a very complicated process. We've signed an agreement with CPSI to do that for us because we already have some of the pieces in place. So we are working on that. Our charge master is already available on our website, so they can see a charge for an individual item, but that's just the gross charge. And then, I thought there was a second part to that, Jerry, but, so I don't know how that'll necessarily impact us, but one thing that HRG does for us, in addition to the charge master review, is they give us a comparison. They pull the data for 5 hospitals in their area. Typically we go Susanville, Modoc, Plumas District, Eastern Plumas, maybe Fall River Mills. And then we're able to compare our individual item prices to our competitors to make sure that our prices are in line.
Okay, and how often do we look at that?
Annually.
Okay. Fair enough. I just wanted to get a better idea of how that was.
Yeah. So again, the price transparency thing is more going to drill down to, what is going to be your, like with purchasing a car or something, out the door cost. Whereas the charge master is the individual charges, gross charges that don't take into consideration contractual terms. So.
That's kind of a tough thing to get to. Is it possible for patients to go, like, say, if they have insurance or Medi-Cal or whatever, is it possible for them to go through that route to figure out what their out-of-pocket would be based on what what we charge? I'm just trying to figure out how a patient is supposed to, or if they can even get down to that level of detail at this time.
Not at this time, but when we fully implement the price transparency, that theoretically will be what we'll be able to provide to them.
Okay. Thank you.
And Medi-Cal, Medi-Cal at the level of service doesn't have any patient liability. They do have a monthly share of cost, but so they're not price shoppers. So
Gotcha.
Typically, but anyway, Medicare people certainly are.
Okay. Thank you. I very much appreciate that, Steve and Chelsea both. Thank you.
Okay.
Yep.
Thank you, Steve. I'm not sure if we have Sean rejoining us or not, so I want to keep monitoring for that. Maybe TK can give us an update in a minute. Questions for TK or Jim regarding their reports?
Hey, Ken. Hey, Ken, this is TK. Just a moment. I'm in the process of letting Sean back in. I'll be right back with you.
Okay, thank you. So I don't know. I didn't hear any questions coming up for TK, so I assume there was none. And Jim submitted a report. Any questions on that report?
And I'm just looking forward to having our new PA start.
Jim, if you're there, I do have just a quick question on your reports. The question really goes to that. I noticed there's a number, I think you said all individuals who left the organization were given an exit interview. What do we do with that information? What happens to that? Is that digested, submitted, analyzed? What do we do with that information?
Generally speaking, I'll be honest with you, if we get 50% return, it's amazing that I can get that much. A lot of times of terminations, they just don't do it. But I do keep them here. I do review them. I look to see if there's any issues that need to be dealt with at the time, because in some cases there are. But for the most part, I just review them and I see if there's anything that sticks out. I haven't gone through them in a while, but yes, when an individual one comes in, I review it and then compare to what we've had in the past, and possibly things may have had, some things may have to be done. But for the most part, they're pretty much the same as far as how they approach.
I'm just wondering if you notice any trends in those things, and then if there are trends, people dissatisfied with one thing or another, or even trends that are positive statements, how we track those. If we look for trends and then maybe have some plan of action to address the trend.
Yeah, I haven't done that, but I think it's something I can do. Like I say, usually it's just because I'm the one that reviews them. I'm the one that kind of knows what's going on, but I should probably get that on paper. I'm more than likely go over it with Sean, so that if there's any training that we need to do with the managers, or if there's a problem with managers, or on the other side, if it's a problem with on a higher level, or just a problem in between as far as fellow employees. But so far, there's been nothing that sticks out that's been too actionable, but I can do that and go over it with Sean on a monthly basis.
I would just ask that you discuss that with Sean and see what his input is on that. And
sure, that's probably a good idea.
Okay.
I think that's also change that we're trying to get everyone involved in.
Ken?
Yeah.
Once before we discussed this idea of exit interviews, and I'm still an absolutely firm believer that the exit interviews don't help much because of the structure of our administration. I think that we should have some outside professional or some independent person review these in addition to the hospital personnel. I know from talking to employees who have left here, they're afraid to put things down on the exit interview because they're afraid it will affect whether or not they can get a good recommendation when they apply for jobs at other places.
Sure.
We in closed session.
I think that's a fair point, but it still speaks to the need to look for that information at some place.
Can you hear
yeah,
me?
but you can't look for the information if they don't give it. If they don't feel free to give that information, you're not going to get it.
No, I hear you. I hear you loud and clear. Sean, I can't hear you. Can you hear us?
Can you hear me, everybody?
I can hear you. No. Sean cannot hear us. Okay.
Hey, Ken, this is Karen. I was in there just a few minutes ago and his whole computer went black, so he's trying to get back on.
Enter your meeting ID, followed.
Try this via phone.
So Karen, in the meantime, how's everything looking over at the hospital?
Enter your participant ID. Please enter the meeting pass.
Hi, Jerry. Everything's looking pretty good.
Meeting now.
We had a full floor for a couple of days, which was really nice, and no COVID right now, so that's great.
And no major issues?
No major issues.
Okay. Thank you.
You're welcome.
I'm not sure if Sean's trying to join via phone or if he's trying to call me or what is exactly happening here.
Hi, Ken, this is TK. I believe he's trying to connect the audio through his phone as opposed to the device. If you wanted to go ahead and go
I can hear.
available.
I can hear. Hey, okay. I can't wait to get back together. I am so done with Zoom. Okay.
All right. Well,
All right. I apologize, folks. Everything just went black. So,
well, can you hear us now?
yes.
Just to bring you up to speed, we did have a small discussion related to exit interviews with Jim. And it asked if we kind of looked for trends related to those interviews, the information that might come out of that. Dr. Walls made the suggestion that maybe those interviews should be done by an independent entity to assure that people were willing to conduct the interview and then report information back. I suggested that it might be valuable information for administration to analyze. So, that's where we left it. That said, we're on to item. I'm sorry, Sean, were you going to say something?
So exit interviews to be done by a third party, not by anybody internal. What was the reason for that?
Well, I'm going to let Dr. Walls speak to it. He raised the concern. So Dr. Walls?
Yeah, can you hear me, Sean?
Yes, thank you.
I didn't say that it could not be done. I didn't suggest that we not do it internally, but I think in addition to that, an independent person to evaluate exit interviews would be important, because I know for a fact there are people that leave here and do not want to put down issues because they're afraid that it will affect the recommendation they might get from this institution when they apply for jobs at other facilities.
Yeah, I can see that. You know, that's part of a little bit of the culture is, you know, I hate to say that retribution is not happening. I would like to say retribution is not happening, but I think that there's an element to that. So I would agree that third party would probably be better, and they can report it back what their findings were.
Can I say, Dr. Walls, when people call for verify employment, the only thing they get is the dates they were employed, and not any kind of recommendation one way or the other. They even asked me, would you re-employ this person? I refuse to answer even that question. So there's not a question of whether they'll get a good or bad recommendation. They only get the dates that they were employed.
Yeah, I've kind of heard along the same of what Dr. Walls is saying. So maybe it's a matter of educating the staff on really what can and can not come out of, you know, a next employer calling the facility to get a recommendation or to find out whether you would employ them.
You know, officially, we have very strict standards. You know, officially, we can only say so much. But you know, it's a small town, it's a small community, it's a small county, and so I think that unfortunately, regardless of what we say, I think that there are people that are willing to talk about the experience that they had with this particular person. So I'm not sure that you're going to be able to quell that because it's not official. But I would love to quell it, but you know, people still talk. But yeah, it's a tough one.
Well, and we've noticed that sometimes there's not many people willing to do an exit interview. So I just brought it up for discussion, Sean, something for you to consider and think about with Jim. Appreciate Dr. Wall's insight on that as well.
Thank you. Okay.
Agendas for next month. Standard agenda, something that we need to add.
Yeah, we were going to appoint members for the Strategic Planning Committee.
That's right. So it's going to be carried over. Thank you.
And we're going to bring those two policies back, I presume. And the speaking of which, the QA policy, and currently the board gets a report on a quarterly basis, and I didn't see that listed in there either. I forgot to mention that earlier.
Can you say that again, Jerry?
The QA policy that came before us that's being tabled, our board
yes.
receives a report on a quarterly basis
Yeah.
regarding those items, and I didn't see any mention of that in that policy, and I'm not sure whether that's appropriate to be in there, but I thought perhaps it might be.
Okay. Okay, and so I'm assuming Renee is capturing this. Okay. All right. That said, we are at 4:56. Why don't we take about 5 minutes to break and we'll move into a closed session. I asked TK to make sure we are meeting in closed session. We don't have anyone else there. I'm assuming, Sean, you and Jim will join us at some point in the closed session?
Yes, we'll rejoin.
Okay. So 5 minutes and we'll regroup, okay? Thanks, everyone. Okay.
We're live.
Thank you. We're on item 16 related to the closed session. The board's closed session has been adjourned and we are now back in regular session. I can report that there was no reportable action taken by the board during the closing session. And I would move, with that said, move on to item number 18, which is our next meeting time, February 25th at 3 p.m. Via Zoom. As such, the meeting is adjourned. Thank you, everyone.
Thanks, everybody.
Thank you.